Aloha and welcome to General Pharmacology. Well, I had something on my mind today to lecture about, and then I got an email asking me if I was going to lecture about something else. So I think we're going to lecture on 2.6 cardiac rhythm today. Matter of fact, I know we're going to lecture on 2.6 cardiac rhythm today. This might be out of order, but it might be good to do this first before we do the second part of 2.5, because usually you see a lot of this before we start getting into the anticoagulants. And so until I got an email from a student saying, are you going to talk about the second half of 2.5 today? I thought, nah, I better cover this. So today we're going to cover cardiac rhythm because this is quite simply something very fun to think about and talk about until you're in the clinical situation, and then this stuff gets really, really scary. And so while we're on the cartoon side of the equation, I'd like to keep this really simple and really fun so that you have some basic fundamental understanding of what you need to know to move forward, because eventually understanding this stuff becomes a very stressful life and death thing. And so we want to try to cover things very simply and very fun the first time around. All right, the very first time I took advanced cardiac life support, it was eye-opening for me. I really loved the curriculum. I think the curriculum has really, I think if you're going to pick one curriculum that has really affected this course, it would be healthcare curricula like what the American Heart Association does with advanced cardiac life support. And so when I was first exposed to advanced cardiac life support, really, really enjoyed that information, enjoyed studying that information, and getting proficient at that information. Something I will say that if you follow this over the years, the recommendations will change from, oh, do this, to, well, maybe not do that. And there will come a time where your own clinical decision making will be very important in this situation. But I would strongly urge you, as we go through this, I'm going to give you the simple side of things. If you want to get really good at it, understand their ACLS website, and then take an ACLS course. Around here, you have to work at a certain place to take ACLS. I think everybody should take ACLS. Where I came from, a hospital that I came from in Ohio, everyone took ACLS. They weren't expected to call codes, but they wanted everyone to be familiar with the process. And so it was a very small hospital in Upper Sandusky, and pretty much everyone was required to take ACLS and take Megacode with me. So I had to do Nice Guy Megacode. So big fan of this curriculum. I really want you guys to take some time out of your life to understand this curriculum, because it will definitely have life and death consequences if you are going out into the healthcare field. When I went to medical school, they decided to teach this to us at the end of our rotations, and so there were situations where me and a few other medical students really wished that we'd had this information early. And so we're going to talk about this. When you get to this point, you'll be advanced cardiac life support. I'm going to take it down a notch. I call today's lecture basically intermediate cardiac life support, because when you teach basic things to people who are not doctors and nurses and healthcare providers, you need to make it a little easier for them. And so that's where this slide comes from. Oh, not this slide, this lecture comes from. If you look at the algorithm for basic life support, at least the one that I put in your notes, over the years these boxes will change a little bit, but you'll notice the overall recipe remains the same. And so they'll call this an algorithm when you start at this box, and then it'll ask you questions, and you'll go down the boxes. And really, we're going to just look at the similarities and not get too complicated, not today. Well, let's make it very, very simple, because this is where it starts. And this was one of the most important things I could do when I triaged as an emergency room physician, and looking at a room full of people who think I'm not moving fast enough. I look out at the crowd and see the people waiting, and I would just do this triage right here in my head. Now these people are pretty easy to pick out. I was the coroner, so I didn't have this problem in my waiting room. However, the emergency room waiting room will be full of people that are somewhere between these two things. And so can you just conceptualize the difference between those two situations? And so that's where triage begins, with your eyeballs, and it's called eyeball triage. And so we can tell the difference between the color That X means that person's unconscious. This person's got its mouth wide open, mouth breathing. You can see the shoulders. Labored respirations, and then if you actually examine them, put your hands on them, maybe you can see their heart rate. When somebody's blood pressure is really high and their heart rate's really fast, when they're sitting in there in the chair, you can see the pulsations in their neck, you can see the pulsations in their head movement. And so, yeah, the general thing is, yes, absolutely, you need to put your hands on the person to check their pulse. But there might be clues that you can take their pulse with your eyeball from across the room. And so when it comes to triaging an emergency room, this is step one. And so it's really simple. The person on the left is doing just fine, other than they've probably been waiting 2 hours and don't have a smile on their face. The person in the middle we need to get to immediately. All right, so normal cardiopulmonary distress. I want you to know the difference between distress and arrest. Arrest just means to stop. Distress means something wrong. We call it cardiopulmonary because your lungs and your heart are attached. And early on, when you're eyeballing the situation, it's really hard to know if it's a pulmonary problem or a cardiac problem early on in the situation. And so we just stick those words together because we're going to treat the two together at the same time. So that's why we'll just call it distress and arrest. Arrest, stop, distress, problem, cardiopulmonary, heart and lungs. All right. We'll take exactly the same words and, well, this person's stable. All right. Now, stable means a flat line, not a flat line on their heart monitor, but a straight trajectory. They're not headed downhill. Maybe we'll do that oximetry lecture sometime. But the person in the middle is unstable, and then, of course, the person on the right is still in cardiopulmonary arrest. And if we witness there's going to be things we're going to need to do, and do quickly, and that's what we're going to talk about today. However, I do want you to know the difference between stable and unstable. And so we'll look at a cardiac rhythm and not look at the patient, and we'll say, well, what does that rhythm mean? And, well, that rhythm means one thing if you're looking at the patient and they're stable. That rhythm means something completely different if you're looking at the patient and the patient's unstable. And so you can look at exactly the same cardiac strip, and what to do with that cardiac strip depends on whether your patient is stable or unstable. What we do in cardiac arrest is pretty consistent. This is something called a 6-second strip. Do not call this an electrocardiogram. That's what we call it in rumor. But electrocardiogram is technically all 12 leads in different positions. And today, we're not going to talk much about that at all. And so what we're looking at is rhythm strips. When we see the electrical signal of the heart in a single strip, we call that a rhythm strip because what we're looking at is the rhythm. It takes 12 of these lined up that are positioned just right to make up an electrocardiogram. That will give us a three-dimensional electrical picture of the heart. But we're not looking at an EKG right here. We're looking at a rhythm strip because it's just one lead. And we can see the QRS complexes in these, and they look normal. We'll talk about that in a second. But what I wanted to draw your attention to is that this is a 6-second strip. And so if we count the number of blips, 1, 2, 3, 4, 5, 6, what is that, 7 blips in a 6-second strip. This immediately tells me that the heart rate is 70. And so each of these blips is a contraction of the heart, the electrical signal of the contraction of the heart, because when the heart's contracting, all these ions move in and out of their channels, causing these electrical signals. And so I can tell from 7 blips in a 6-second strip that their heart rate is 70. Those blips are called QRS complexes, and we will get to that point. We're going to talk about the most important rhythms that you can talk about in advanced cardiac life support, and certainly at an intermediate level, is sinus rhythm. And so one of the things that we would do in our hospital is get everyone to just recognize what sinus rhythm was, and we'll go over this again, but notice all the P waves are the same. They come before each and every QRS complex. Each and every QRS complex is uniform and the right width, and then every QRS complex is followed by a T wave, and they're all uniform pretty much with the previous one. And it is a specific rate. It's not faster than 100. It's not less than 60, the heart rate. And so we'll talk about why this is a sinus rhythm. And again, the heart rate's 70 because we have 7 QRS complexes in a 6-second strip. We'll talk a little bit about what atrial fibrillation is. The atria are shown by these little P waves here. So the little chambers of the heart are atria, and they're made by those little P waves. Notice our little P waves have disappeared and become this fibrillating. Fibrillation has to do with a bag of snakes, and if we ever Google fibrillation, see a heart fibrillating under the camera, it looks like this bag of worms or a bag of snakes, and so you can see this irregular electrical pattern behind the ventricular contractions, and so that's what we're going to talk about today. Atrial fibrillation is problematic for people because that quivering of the atria causes blood clots to break loose, and they can go to the brain and cause stroke. And so atrial fibrillation is the leading cause of stroke, and atrial fibrillation is the major reason that we put people on the anticoagulants that we talk about when we talk about lecture 2.5b, the second half of that. All right, when it comes to clinically treating atrial fibrillation, we're going to be on the lookout for something called atrial flutter. And see these little P waves? Flutter means the atrium are a little more organized. The electrical signal is a little more organized, but they're fluttering in a uniform way like a butterfly wing, and so that's where atrial flutter comes from. For beginning purposes, the treatment of atrial flutter and the treatment of atrial fibrillation is going to be the same, but I wanted you to be aware of what atrial fibrillation is. I consider flutter to be kind of a variant of fibrillation, but I wanted you to see the difference between the two. And we'll come back to that. Supraventricular tachycardia, tachy-fast cardia heart rate. And so the first thing I can tell you is there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18 QRS complexes on our 6-second strip. This person's heart is beating at 180 times a minute. And so if it's beating that fast, that means it's not having time to fill. And so if it's not having time to fill, then it's not able to pump in a perfusing manner. It's not able to pump in an effective manner. So you get heart rates this high, the heart starts to fail. And so supraventricular, that means the rhythm is coming above the ventricles. We know the ventricles are firing together because the QRS complexes are narrow, because you have 2 big ventricles, and when they fire, they make these great big blips, and when they fire separately, there's 2 big blips. And when they fire together, there's just 1 big blip, and we call that narrow complex. And so if we look at these big electrical spikes, the big electrical spikes are the big ventricles contracting, and we see with each QRS complex that the QRS complex is narrow, and that means both ventricles are firing at the same time. So the signal causing this must be coming from above the ventricles, supraventricular, because if this was a ventricular rhythm, then one of the ventricles would fire first and then cause the other ventricle to fire, and that would lead to a big, wide, ugly QRS complex. And so that's why this is supraventricular. The narrow QRS complex shows us that the signal is coming from above the ventricles in the pathway, and we're getting ready to talk about all that. We hear about this a lot, heart block. What is heart block? Well, there's 3 different kinds. There's first degree, second degree. Of course, there's 2 kinds of second degree, Winky-Bach 1 and Winky-Bach 2. We're probably not even going to ever talk about that because we don't really treat that so much differently. However, we will talk about third degree heart block, and so I want to separate third degree heart block from anything else. All right, so let's go back to first degree heart block. First degree heart block is a long P QRS time, and so notice the P wave occurs a long time, a longer time than what we consider to be allowable. Now, when you're in the emergency room and you're looking up at this rhythm, you don't have your little calipers out to measure exactly, but maybe you'll keep an eyeball on this, because this would be sinus rhythm if the P wave right there, these P waves that are all exactly the same distance from the QRS, if it was just a little bit closer to the QRS complex, this would be sinus rhythm. However, the P waves are a little far from their QRS, and so that's first degree heart block. We'll talk about that in a little bit. But something that you have to be able to recognize is complete heart block. And so something we'll go back and show you is each P wave causes a QRS complex. Okay, that's what happens in sinus rhythm, and in first degree heart block, each P causes a QRS. Just takes a little longer. All right, but notice here, the P waves and the QRS complexes have nothing to do with each other, and that's complete heart block. And this is something that we have to be able to see and intervene on. Now, if you're a hospital employee, we didn't expect you to recognize a third degree heart block, but something that I wanted to be very clear is that third degree heart block is bad. And first and second degree heart block, you know, that gives it, we have time to sit around and think about and be experts about and talk about while our patient's wondering what we're talking about. Third degree heart block tends to be an emergency that we need to deal with. It is an emergency for us to deal with, and we can see this from the 6-second strip. What is this person's heart rate? Well, they have they have 4 QRS complexes in our 6-second strip, so their heart rate is 40. And so we'll look at them. They're probably not doing very well. And when you see this, when you see third degree heart block with a heart rate of 40, they're usually unconscious on the table. And you can see the little P waves, P wave, P wave, P wave, P wave buried in the T wave, P wave, P wave, another P wave buried here in the T wave, P wave, P wave. And so if you got your calipers out, you'd see the P waves are all identical to each other, except they're and separated in time. However, they're all completely separated from the QRS complexes. And so this is the stuff I want you to be able to see. All right, being able to recognize ventricular tachycardia is a life and death thing. And the first thing we want to know about ventricular tach is, does it have a pulse? And so we know this is, we call this ventricular. It's not supraventricular because the QRS complexes in this situation are wider. And it's not a great example. But what I can tell you is these QRS complexes are wider. This is what makes it ventricular rhythm, and then we call it tachycardia because there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 blips in a QRS, 17. So this heart rate's somewhere between 160, 170. And so people, when their heart rates are beating that fast, they don't have time to fill, and so this tends to be a life and death situation. If they have a pulse, they're sitting there feeling fine, we have time to think about it. And so this is one of those situations where we'll look at the rhythm and we'll say, hey, how are they doing clinically? And so you can put that in your notes. VTach, if they have no pulse, then we're going to treat them like what we're getting ready to treat the next person. If they do have a pulse and they're doing okay, well, then we have time to think about it. And so when we look at these rhythms, the question you want to ask yourself, question mark, is this perfusing? Is this causing a heartbeat that is adequate, sufficient for the organs? And so if they have this rhythm and they're getting adequate perfusion, great. We have time to decide what we want to do. This is not and never has been and never will be a perfusing rhythm. This is cardiac arrest. Now when you watch TV and they do cardiac arrest, it's this flat line. And we're not even going to talk about how to treat that today because this is what's most common when you see cardiac arrest in a clinical setting. You'll see ventricular fibrillation. And fibrillation just means that the fibrillation is like bag of worms where if you saw a heart that's fibrillating, you would see this pattern, and so I'd encourage you to put ventricular fibrillation into YouTube and look at the videos of heart fibrillating. And so notice the electrical signal is completely random, erratic, and so this is not a perfusing rhythm. This is cardiac arrest. And so when we taught ACLS in the hospital, we expected every employee to know the difference between a sinus rhythm and ventricular fibrillation. And so I would encourage you, if you learn nothing else from this lecture, make sure that you can identify a sinus rhythm and what those components are from ventricular fibrillation. And notice that ventricular fibrillation never has a pulse. Now atrial fibrillation we talked about, it can have a pulse. The atria are the little chambers, but the ventricles are the big chambers. If they're fibrillating, this person is in cardiac arrest. All right. All right, so each cardiac muscle cell can repeatedly contract or beat by itself. If you take a physiology class, they make this much more complicated than I'm getting ready to. However, something I can tell you is that each cardiac muscle cell can beat by itself. It has this internal clock that allows it to keep time for itself. If it's not getting the signal it thinks it should get, then it can just start beating on its own. And so the cardiac muscle can repeatedly beat and contract all by itself. And to be able to do that, the solution of ions really has to be perfect. And so when we get to endocrinology, we're going to talk about body systems that keep the bath water perfectly salted in such a way that we can have action potential of a neuron, but we can have action potential of the heart as well. And so the heart requires these ions to be perfectly balanced, as does the nervous system, and our endocrine system is responsible for keeping these perfectly balanced. And so as we go through the pharmacology, you'll hear about sodium channel pumps, and sodium channel blockers, and calcium channel blockers, and potassium channel blockers, and maybe we'll even talk about chloride channel blockers. All right, if you take a picture out of a good pharmacology book, you might see this right here. And so this came out of one of Katzung's books, I think. And here is the voltage inside of the cell, all right, over time. So we're going to start here, and we're going to move in this direction over time, to the right over time. And notice that the voltage inside of the cell is going to start out negative. That's what I want you to, that's negative, all right? And then something's going to happen to cause that the voltage to go away, all right? They say, oh, the voltage is going up. Yeah, what it's doing is it's going away, all right? It's depolarizing. 0 means the battery's dead. And so this sodium-potassium pump over here, that's what they're trying to show you, the sodium-potassium pump here. Sodium out of the cell, potassium into the cell. It's what creates this negative 85 millivolts right here. Creates the electrical force. And this is 85 negative on the inside. That means positive 85 from the outside. Don't be confused by all that. This means the battery's charged. This means the battery's dead. This means the battery's being recharged. And now the battery's charged and ready to fire again. And so we're looking at cardiac action potential. Battery charged and ready. Battery dead, battery needs recharged, battery ready to fire action potential again. And notice there's all sorts of bouncing. Nothing ever happens exactly stop and then go. All right, and so to cause this, notice we'll have this big rush of sodium coming in. That's what that big black arrow is for. And then notice these little arrows, that rush of sodium will slow down eventually. And that'll affect how calcium rushes in. And calcium rushing in is what activates the muscles to contract. And then it's potassium leaving that resets the cell for another action potential. So notice this is going to look just like the neuron. When calcium came rushing in, it was to facilitate the release of the vesicles in a neuron, to release neurotransmitter. In a muscle, it's really no different, except instead of the little things that push vesicles out, the calcium is coming in and facilitating fibers to ratchet on each other to contract muscle. And so you'll notice the action potential is really no different, not much different than a neuron. The big difference here is calcium, when it comes rushing in a muscle, is to move the muscle. When the calcium comes rushing in for a neuron, it's to release the vesicles. Over here, they want to show you the sodium-potassium pump, which we've talked about before, and then this thing called a sodium-calcium exchanger. I think we have a couple of slides about that. And then the diastolic slow channels. I'm going to let you guys research that to your heart's content, because we don't really talk about that too much in a clinical situation. All right, here's the cartoons I've been waiting for. All right, so here's our sodium-potassium pump. It pumps sodium out of the cell, pumps potassium into the cell. This goes on everywhere. pretty much all the cells have a sodium-potassium pump. And anyway, this pumping the sodium out of the cell creates a positive charge on the outside, and the sodium force trying to drive the positive charge into the cell. And so when you look at the negative 85 millivolts, well, it's negative on the inside and positive on the outside. And so there's an 85 millivolt potential energy across the membrane. And so anyway, the sodium-potassium pump, it creates this sodium force. Now, sodium is trying to drive into the cell because it's a negative 85 millivolts on the inside, attracting this sodium. Plus, there's a higher concentration of sodium on the outside, and everything in water moves from higher concentration to lower concentration, unless you got a bunch of pumps pumping it the opposite direction, well, like we do right here. All right, something they talked about is the sodium-calcium pump. Occasionally we cover that. And so this sodium force, we talked about the sodium force in the second lecture about this is the force that we drive in nutrients like glucose and amino acids. The sodium force is the same way that we can pump calcium outside of the cell to create this calcium gradient. Now remember, it's positively charged outside of the cell and a higher concentration of calcium outside of the cell. Not only have we created this sodium force, but now we've created this calcium force. So then when we open calcium channels, calcium can come rushing in. All right, so what did we talk about so far? We talked about the sodium-potassium pump. It uses ATP to pump sodium out of the cell and potassium into the cell. And it does it in such a way that the outside of the cell ends up positively charged and creates this sodium force, the sodium gradient, where the sodium is trying to come back in. Not only is it the positive charge causing the sodium to rush in, but the concentration gradient. Remember, it's more positive, there's more potassium inside of the cell, and so once the action potential ends, it's potassium rushing out of the cell that actually resets the membrane, not the sodium-potassium pump. The sodium-potassium pump just creates the battery to begin with, but it's the potassium channels that reset an excitable membrane. We talked about that in neurotransmission, and it's the same thing with any excitable membrane. And then we talked about a sodium-calcium pump to create this calcium gradient as well. So when we talk about action potential, we can divide it up into steps. Step 1, sodium channels open, so sodium comes rushing in, causing a voltage change across the membrane. So we've seen this before. All right, and so here, the sodium force is driving sodium into the cell, not only from its concentration gradient, but its electrical gradient. And then calcium will cause rush in, causing muscle contraction. And then what resets the membrane is the potassium channels opening, allowing potassium to rush out, because at this point of the action potential on this part of the membrane, the voltage is now switched and is back to negative 85. Now that the voltage is zero, there's a higher concentration gradient to push the potassium out of the cell. And then that resets it, starting us over again. And so that's what I want you to see when you look at something like this. We didn't talk about chloride ions in the transaction. We didn't talk about diastolic currents. And so this is during action potential, during systole. And during diastole, there is this slow flow of sodium into the cell, slow flow of calcium into the cell, and slow flow of potassium out of the cell. They wanted you to see that. We don't talk about this too much clinically, but drugs that affect this part of the action potential we'll talk about a lot. All right, so again, these ions require a perfect bath for the cardiac muscle to function properly. It has to be bathed in these ions and glucose as well. And each cardiac muscle cell has the ability to not only pace itself, but with others around it. And so when there's a normal pacing system in your heart, and we'll talk about that, but when your pacing system comes outside of that, when one of these cells takes over your pacing system, we'll call that an ectopic rhythm. Ectopic means outside of where it's supposed to be. And so an ectopic pregnancy means a pregnancy outside of the uterus. And an ectopic rhythm means outside of the conducting system. And so each of the cardiac muscles has the ability to be that ectopic pacemaker for the entire heart, because it can sit there and beat by itself, and all it needs is some friends to join in with it, and that's called recruitment. And so that all comes from each of the cardiac muscle cells are able to pace the heart if the heart's not able to pace itself properly. Well, the problem with that is all the heart cells start beating separately and on their own, and there is no organizing rhythm. There's nothing to slap them and say, stop what you're doing and work together. You know, sometimes humanity needs that, and occasionally our hearts need this as well. And so you'll hear about different ways to treat fibrillation. One of them is a precordial strike on the chest for ventricular fibrillation. You've seen people get shocked with those heart paddles, clear and shock, to stop this and get them to work together. Because when the cells, just like people, beat separately and on their own, then it's fibrillation. And ventricular fibrillation, if the heart cells aren't working together, then your heart is not beating, and that's why fibrillation is death. Ventricular fibrillation is cardiac arrest. So when the ventricles, the main pump, are fibrillating, there cannot be a heartbeat. And so that's the point of this whole part of the lecture, is ventricular fibrillation is cardiac arrest. And that's why it looks like this when you look on the rhythm strip. It looks like each of the muscles are just doing their own thing. And if you look at it, if you look at the videos of ventricular fibrillation, this is basically what it looks like, except not with, PowerPoint tubes. We want the heart to be synchronized. That's why there's a pacing system in it, and that's why the heart cells are designed to listen to the one next to it and beat in the way that they are instructed, okay? Because this is how we want our cardiac system to work, our myocytes to work in a synchronized way. That's so the valves can work properly. By the way, there's some heart sounds videos. They were very high fidelity and awesome when I first uploaded them. YouTube over the years, I don't think the sounds have done so well, but there's a set of heart sounds on the YouTube channel. Plug in your headphones, listen to them. If you want to get real good, use your stethoscope, plug in your headphones and put your stethoscope up against the headphones and watch the videos as it makes heart sounds. And I think that was a commercial. All right, now to maintain conduction, there are heart muscle cells that conduct the signal. The conduction pathway is heart muscle cells. Now they're very excitable and they have neuron properties, but they're not neurons. They interact with neurons, but the conduction system are specialized heart muscles, and they are designed to maintain this synchronized conduction through the heart. And so the conduction system starts in the sinoatrial node. The atrium in the right atrium of the heart is where the SA node is. That's why in congestive heart failure, and this right atrium will start to get bigger and enlarge because of heart failure, and that will damage the system. And so people with heart failure are notorious for getting, people with heart failure it's very common for them to get atrial fibrillation because of the stretching of this pathway. And so the sinus is a little cave, and it says if you take a heart and you look at it, there's this little place about the size of the tip of the pinky, and you can see, and that's called a sinus. A sinus is any kind of hole. And so right where that little hole is where our pacemaking starts, and so that's why they call it the sinoatrial node. And you'll hear about a sinus rhythm, and you'll be like, wait a minute, these are my sinuses, what they say on TV. And medically, a sinus is just any empty space. And so that's why a sinus rhythm doesn't come from your sinuses. A sinus rhythm comes from this little cave in your heart. Anatomically, what that means, nothing. However, that's how it got its name, because they were looking at it and they're like, well, it's in this little sinus here. We'll call it the sinus node. It's the sinoatrial node, the SA node, and this is where a sinus rhythm begins. It's carried to the atrioventricular node, AV node, from the atrium to the ventricular node, and goes to the right and the left atrium. And so you can see here that when the rhythm starts from the AV node, when the signal starts from the AV node, then it goes to each of the ventricles at the same time. when one of the ventricles fires first and then the other ventricle fires afterwards, then we get a wider QRS complex. And so the wider QRS complexes tell us that the rhythm is not necessarily starting in the AV node. The neuron from the sympathetic nervous system will synapse on this pacing system and secrete norepinephrine, increasing heart rate. The parasympathetic neuron coming from the vagus nerve will carry acetylcholine to synapses along the conduction system, slowing heart rate down, slowing the action potential down. All right, so let's look at this QRS complex right here, PQRS-T complex. All right, we're going to look at this. They call it an EKG, but this is basically our PQRS-T complex. And so here he's connected to an EKG. Notice he's connected to several leads, and we'll see 12 of these. And sometime I'll make a lecture about a 12-lead EKG. Today we're just starting with simple rhythm strips. All right, notice that when we look at the electrical blip of the heart signal, and this is caused by, we put electrodes on them, and these electrodes can sense the voltage changes that occur when ions are flowing in and out of the heart, because when the ions like sodium and calcium and potassium flow in and out of the heart, they create voltages. You move a positive charge in one direction, then an electrical sensor is going to sense the positive charge moving in that direction. If the charge is moving the opposite direction, then the electrical sensor will sense the opposite. And so we can put electrical sensors on the person and sense what's going on electrically inside the heart. And it paints this picture, and we can see that picture and translate that into the muscular movement of the heart. And so it gets really complicated, and so we're going to start this very simply. We're going to just start with P, QRS-T, and you know what? For now, we're just going to call these QRS complexes. You don't have to know the difference between Q and R and S and S1 and S2, S prime, or R prime for that matter, or significant Q waves. So I want you to know P, QRS as one thing, and then T, all right? Because this is the electrical signal that we see when we record the tracing on the heart. All right, so there's our P wave. You can think of it as like the lighting a fuse, and so that P wave starts in the SA node, and that's the electrical signal causing causing contraction of the atria, the small part of the heart. Well, then after a certain amount of time, not immediately, there should be a little bit of time to go down from the AV node, to start from the SA node to the AV node, and for the AV node to carry that signal into the ventricles, that takes time. And so when the ventricles go off, because they're the biggest muscles, they're going to make the biggest electrical noise. And so the ventricles contracting are this QRS complex. If they both do it at the same time, if both ventricles contract at the same time, my QRS complex is narrow. If the ventricles fire at different times, my QRS complex is wider. And then potassium exiting to reset the membrane causes this T wave. This is called ventricular repolarization. And this is done by the potassium channels opening and resetting the action potential. And then it happens again. The atria light the fuse after a certain amount of time. The QRS complex shows the ventricles are contracting, shows the signal causing the ventricles to contract, and then the T wave is repolarization. People will throw this in real quick. People like to say that this is the electrical signal caused by the heart contracting, and that's actually not true. This is the electrical signal that causes the heart to contract, because you will see very, very rare situations where somebody can have a normal sinus like this and be in cardiac arrest, because this is electrical signals completely dissociated from their heart actually contracting. So we're not seeing the electrical signal of the actual heart contraction. We're seeing the electrical signal that should be causing the heart to contract. And so I want you to keep that little difference in mind in case you come across things like pulseless electrical activity, electromechanical dissociation. But the near entirety of time, you see this, you see the patient perfusing. This is a normal rhythm, okay? And that's why we call it a sinus rhythm. Sinus rhythm is normal, all right? And so that's why you always want to look at your patient. How are you doing today? Well, I feel great. Great. That's a sinus rhythm. Okay. And we can see from the 6-second strip, their heart rate's 70. Okay. Synchronized, not synchronized, ventricular fibrillation. All right, so this is cardiac arrest. All right, so let's move to this person who is in ventricular fibrillation and deal with them as rapidly as we possibly can. And so what do we do? And you'll notice that this is easy to think about when you're looking at the page, and oh yeah, this is easy. And it's easy to think about when you're on the comfort of your couch, but one day this will be a real person, and that'll be a real rhythm, and it'll be really you responsible for dealing with it, and then all of a sudden you're going to wish you had a lot of stuff memorized a lot better than you're going to learn in this course. And so something I would urge you to do is memorize ventricular fibrillation algorithms, at least in their current state, or the one in your book, the one I give you that's old, is good enough for now. All right, so what are we going to do with that person? All right, well, we're going to start with basic life support. Remember, chest compressions. Look, if you can't feel a pulse, they need chest compressions. I used to work with these cardiac doctors that would get their ultrasounds out, and they would be able to tell, oh, that the heart beating because of this pulse on the ultrasound machine. I'm like, well, it's not the pulse on the ultrasound machine that determines whether they get chest compressions. If I walk up to a person, they are unresponsive, they do not have a palpable pulse, they need chest compressions. I don't care what the ultrasound thing says. And so we start with basic life support. Annie, are you okay? They are unconscious, they do not have a pulse, they need chest compressions, and they need to be done correctly. All right, and so pulseless arrest at the top of the algorithm, basic life support. Great, your CPR stuff, all that stuff that they taught you in CPR, that's what you have to know to at least start advanced cardiac life support. And a lot of the errors that I've seen in advanced cardiac life support start right here. Why don't you start with basic life support and get help? Great, give CPR, step one. And so this is a great place to start. And so if you're going to be an expert at ACLS, I would suggest that you start right here at this line. Be an expert at basic life support, get help, give CPR. Put oxygen on their face. I've heard all sorts of arguments about this. Look, if they're blue and unconscious, you can put oxygen on their face. Once they're up and talking and we have a pulse ox machine, then we can argue about it. So get oxygen on their face when you're coding people. And then hook the machine up whenever it becomes available. And see, that's the thing. In TV, they want something and it all shows up immediately. And in reality, you want something and it takes time. That theme from Jeopardy song has played in my head more than once, all right? To do chest compressions properly, you have to do 100 a minute. That's, I guess, the rate of staying alive for those of you who actually watch Saturday Night Live. But the chest is being compressed at about 100 times a minute. All right. Staying alive. All right. One of the most important things is to allow for full recoil. Us big guys, we get on top of somebody, we push down on them, but we don't take the time to pull back. And so we have to allow for full recoil of the chest. We push down, and then when we come up, we don't have to take our hands off completely, but make sure that you're just not pushing on them all the time, that when you come up, that brisk upstroke and allowing the chest to refill, that's actually what's most important about chest compressions. They call them chest compressions. It's the pushing part that's almost as important as the allowing for recoil. And so after you push down, if you can get the chest, if you can come off quickly, let that chest recoil quickly, fill up full of blood, you're going to be doing better chest compressions. So this is really the most important part of the algorithm right here. Because if you're not doing this right, all the pharmacology in the world isn't going to help your patient if you're not doing chest compressions properly. All right, so there's this little green thing on the wall, and it squirts out oxygen when you twist this little dial right here. And if you don't know what to set it at, just turn it all the way up with the ball all the way at the top, because you can't go wrong with that until somebody comes along and knows better. And then this right here, down at the bottom, will be connected to a tube that's connected to something called an AMBU bag, a valve bag valve mask. And so this is what we'll use to do artificial respirations. Now they have machines that can connect to the mask and do all this difficult work manually. But the most important thing I can tell you is to make sure that the oxygen is connected to the bag valve mask, and please turn the oxygen up enough so that the bag inflates. I don't care what the stewardess at Southwest Airlines tells you. The bag needs to inflate when we are operating a bag valve mask. All right, and so this is one of the most important things we can do. Make sure this is connected to that, because if you pay attention long enough, you will hear all sorts of horrible stories about somebody who was being ventilated during a code, and this was not connected to that. All right, so the very first thing I ever did when I would walk into a room and call a code is to make sure that the spaghetti is properly attached. All those little plastic tubes everywhere, and they're all disorganized. And I would follow and make sure that when I followed this oxygen tubing, it was actually going into the bag valve mask. And then you listen to it hiss, and the air inflate. That helps you, the oxygen inflate the bag. That helps too. And so make sure that this is connected to that. All right, so we're doing chest compressions. We have connected this person to our bag valve mask. And finally, it's time to try something else. And so we've determined that this person's in ventricular fibrillation or pulseless ventricular tachycardia. So we're going to treat the ventricular tachycardia just like ventricular fibrillation. And we're going to give them a shock. In the old days, we used to give them 3 shocks. Here, we're giving them 1 shock. You're going to meet all sorts of people who want to shock them in all sorts of different ways. And shocking them once is a very good thing to do. Now we just turn it all the way up. For all you old people who remember the 3 shocks, we used to do escalating shocks. It would be like the first shock at 200 and then 260, 360. We don't do that anymore. We shock them at full blast. They're in cardiac arrest. We don't have to worry about causing burns or doing something improper to make things worse. They are technically meeting the specifications for death, and so that's why we say, hey, let's turn the machine up full blast. In the old days, it was monophasic. The electricity means passes in one direction from a negative to a positive in one swoop, and they would say it was 360 joules on an old monophasic machine. 360 is the highest setting, and so if you are in a cardiac arrest setting dealing with VFib, you want to turn it up to its highest setting. In a biphasic machine, they're more modern. That means they send the electricity one way and then they have it come back. And that's what the biphasic is. So because it's biphasic, you'll notice that the joule settings will be about half of what a monophasic setting should be. And so 360 is pretty much the max. 200 is pretty much the max on a biphasic machine. If unknown, just turn it up all the way. All right. And then AEDs, we'll talk about those. We'll skip that. You don't choose how an AED shocks, an automatic external defibrillator. All right, so this is our cardiac rhythm on top of a way old school picture I took of the old HP. When I coded people, this is the machine that we used, not the exact machine. This is covered in dust, and the power of PowerPoint has brought it back to life. All right, so you've determined that we are going to defibrillate this rhythm. The most important thing you can do is get people to stand clear, because during a code, we're using normal saline. It's probably leaking out everywhere, making it wet and wet on the floor. And if you have body parts attached to any part of that, the saline wetness on the bed, then you're going to be part of the electrical signal, and you might have a bad day. We'll have more victims. So the most important thing you can know as a rescuer is don't be a victim. That's rule number 1. Don't be a victim. Because if you're a rescuer who becomes a victim, you've made things a lot worse for all the other rescuers. So the most important thing you can do as a rescuer is make sure that you take care of yourself. And so you would fail megacode if you did not use these words right here. Clear. Stand clear. Some people will make you say that. Right? Clear. And then we're going to give him a shock because the shock will cause those fibers to stop for a little bit, and then maybe when the heart starts beating again, they will synchronize together. And so that's what we do when we defibrillate. That's why it's called a defibrillator. We see fibrillation, we give them an electrical shock, and hopefully after the electrical shock, we have a synchronizing rhythm. Now you're going to want to check the blood pressure, make sure that rhythm is perfusing. Every pulse has a pressure, and so that's the important thing to know. And so I've been in plenty of codes where everybody's celebrating this moment of synchronized rhythm on the heart strip. Unfortunately, their blood pressure is like 60, and it's not really a perfusing rhythm. And so after you've had a change, after a shock, then you want to immediately know what your pressure is, and then in the algorithms there will be things that you need to do once you have converted a rhythm. And so again, applying the shock to the heart is called defibrillation. The thing called an AED is an automatic external defibrillator. They teach you that in basic life support. There's all sorts of free online stuff that you can go study to study AEDs. Please learn to use one. I spent a lot of time using that Hewlett-Packard machine for emergency room settings, and when I was in an emergency room, I was expecting emergency room settings. When I was an emergency room doctor, then I would expect emergency room things, and so it really wasn't unexpected when I'd use the Hewlett-Packard machine, and it's more difficult, but I understood how that worked just fine. And then one day you're out minding your own business and somebody's in cardiac arrest, and now all of a sudden you have some AED machine in front of you that you've never used before, and they're all looking at you like, well, gee, you're some kind of expert. I thought you knew how everything worked. And AEDs are simple. You attach them to people, you press the green button, and you wait. But there are some rules that go with those. And so I urge you to take the time to make sure you understand how an AED machine works. And then when you're walking around a public place, you keep an eye out and try to remember where the AED machine is, because they will find you, I assure you. All right, so this person's in ventricular fibrillation. We're doing chest compressions at 100 a minute, and we are ventilating this person. And I think we're going to shock him at when we shocked him at 360 joules on a monophasic machine. We shocked him at 200 joules on a biphasic machine. And the interesting thing is that you have to take their chest, they have to stop compressions. And matter of fact, they have to stop compressions to even see this rhythm. When the person's doing CPR, you can't see this on the rhythm strip. You have to stop CPR for them to see this on the rhythm strip, and it's chest compressions that's keeping the person alive. So you stopping CPR so you can look at the rhythm, it's not helping the person, and I'll give you a hint, it's doing exactly the opposite. So when you're calling a code and chest compressions are going on, you need to be able to stop compressions and be able to recognize this rhythm in less than 6 seconds and start chest compressions up again. So you need to be able to identify the ACLS rhythms immediately so that you don't have to stop chest compressions so long to see this. And so that's something unrealistic about this slide. When chest compressions are going on, the rhythm strip just looks like an electrical signal just bouncing straight up and down. So you have to actually stop the chest compressions to even see this. And we see that and we know they need to be shocked. We shocked them once, maybe we shocked them 3 times, depending on which escalation algorithm your code caller is looking at. All right, so we gave 1 shock. Okay. And then we keep giving CPR immediately after the shock, IV or interosseous. We can put some of this stuff directly into the bone. Give vasopressor. The vasopressors they're talking about is epinephrine during CPR before or after the shock. So whatever is available, give first. That's what they're telling you. In the old days, we used to say, oh, epinephrine comes first, and there used to be lidocaine comes first. We don't do lidocaine first anymore. Epinephrine, we can give vasopressin, all right, and we've talked about these things. Epinephrine is adrenaline. We're going to use it in cardiac arrest. We can give 1 milligram. We can do that every 3 to 5 minutes. We can give 1 milligram. We can give 3 milligrams. We can give escalating doses of epinephrine. We used to do that. Amiodarone used to be the drug of choice when they trained me. At first it was epinephrine, and they're like, oh no, give amiodarone first. And now it's back to give epinephrine first, I think. They change that all the time. So you want to know epinephrine, vasopressin. Vasopressin is an excellent drug to give in cardiac arrest. Epinephrine produces beneficial effects in patients during cardiac arrest, primarily because of its alpha-adrenergic stimulating vasoconstrictive properties. All right, so I cut and paste that off the website for ACLS, and we should be in the point of pharmacology where you understand what this means. And so if you're not sure what this means, if you can't read that and understand that, then you want to go back and look at autonomic pharmacology and look at the antihypertensives. We're going to talk about vasopressin, antidiuretic hormone, more when we talk about endocrinology, but that's how it got its name. Vaso as in vascular, pressin as in pressor. It raises blood pressure. And so that's what antidiuretic hormone does. It raises blood pressure, stimulates cardiac activity. All right. Somewhere else on our algorithm is amiodarone. And this is, if I was standing around calling a code and this was in my hands, this is probably what I'd use first. This is what they trained me to do. Lidocaine is important to be able to use. Something that's down at the bottom of the algorithm is consider magnesium. I think this is safe. You can give magnesium pretty much anywhere in the algorithm, and I would suggest, unless they have some kind of magnesium toxicity risk, which is very rare, I would suggest that this belongs at the top of the algorithm. I've seen all sorts of people go in and out of VFib over and over and over again, and really, what it really was torsades, and they needed magnesium. And so this is something that it's not really a drug, it's a nutrient, and I think putting a gram of magnesium when you have a very brittle fibrillation patient, I think this should go at the top. Anyway, we're talking about amiodarone, or lidocaine. Lidocaine is a sodium channel blocker, the same lidocaine that they use in dental hygiene, or the same lidocaine that we use as a local anesthetic, the same lidocaine that we're going to use as a class 1 antiarrhythmic. So the point here is that anything that is a sodium channel blocker will be called a class 1 antiarrhythmic. They'll divide it up into class A and class B. If you guys are in the cardiovascular forum section, maybe you can describe the difference between class 1 and class 2, or class A and class B, class 1A and class 1B antiarrhythmics. All I need you to know are the sodium channel blockers are class 1. Class 3 is a mixture. Class 3 antiarrhythmics, we skip class 2, we'll get there. Class 3 antiarrhythmics just have a mixture of any of the other things. And so if anything that's a class 3 like amiodarone, it's going to just have a mixture of properties. It's going to block sodium channels, the one we talked about in action potential, potassium channels and the calcium channels, and then they can be alpha or beta blockers. And so when it has this mixture of activity, we'll call it class 3. All right, we'll come back to the antiarrhythmics. All right, we've done chest compressions. We've given oxygen. We've shocked them. We've spent an hour just talking about these 4 drugs: epinephrine, vasopressin, lidocaine, and amiodarone. And so I will ask you about those. However, we did spend an hour talking about how to properly do certain things during a code, because if you don't do those things properly, there's no point in understanding anything about this. And so when I read Katzung's Pharmacology for Cardiac Arrest early on, it talked about all this drug and ion potential stuff, which was really interesting. But my students really kind of need this hands-on understanding of how to deal with cardiac arrest and from this team approach. And so being able to do CPR correctly, being able to instantly identify rhythms, it's going to be far more important than knowing whether we should use amiodarone before vasopressin or after epinephrine, and whether we should escalate it. So really, I just want you to know these 4 drugs for ventricular fibrillation and know them very well, because someday you're going to wish you knew them better. Please do not confuse these things. When you have VFib, your heart cannot beat. When you have AFib, then it's the leading cause of stroke. And so that's what we see. Instead of P waves causing each QRS complex, we see this fibrillation causing each QRS complex. Because if you look at a sinus rhythm, each P causes a QRS, and each QRS is followed by a T, and they're all uniform. And here we see these nice QRS complexes, but we don't see any real P waves. And so that's atrial fibrillation. Here, 1, 2, 3, 4, 5, 6, 7, 8, their heart rate's 80, but we see it's irregular. And in atrial fibrillation, we'll call it irregular, IIR. The problem with atrial fib is that clots can form. When the atria aren't pumping, then clots will form, and they can break loose and cause stroke. And so atrial fibrillation is the main reason that we put people on blood thinners. In the old days, we'd give warfarin, Coumadin. Now you can put factor, we'll talk about factor 10A inhibitors. Those are very common reasons to use those drugs. However, we don't really want to convert the atrial fibrillation until we've taken a look to make sure that switching them over to a sinus rhythm isn't going to cause a clot to break loose. And so when we do the echo for AFib, sometimes we'll put the echo down their throat like we're doing an EGD, like we're using a camera to look at their stomach. But we'll use basically the same device with an ultrasound so we can see right through the esophagus and see right up against the atria, because they're easier to see, at least for the doctor, to see looking from the esophagus than they are looking through the ribs. And so I think we wanted to go back and show you that again. Again, we don't want to convert atrial fibrillation until we know that there's no blood clot. Sometimes we'll leave them in AFib until we start dealing with the blood clot before we consider converting them. But that depends on whether they're stable. You'll see somebody with atrial fibrillation and they'll feel fine. They don't notice a thing. You'll see exactly the same rhythm on the other person and they're having a crisis. Now this person's having a rapid ventricular rate, and so even if we had the same heart rate between the two, I've seen people who are just unstable when they're in atrial fibrillation, and if they're unstable in atrial fibrillation, then we're going to have to give them an emergency shock. But if they're stable, then we have time. And so it's really not about the rhythm. It's not about what the atrial fibrillation looks like. It's about whether that rhythm is stable or unstable. And again, this one has this rapid ventricular response, so they're going to need to be treated. We might start with digitalis, digoxin, lanoxin. It slows AV conduction and is commonly used to slow down ventricular response to atrial fibrillation. But it can be very toxic with hypokalemia, and so that's why we worry about drugs with Lasix that cause potassium loss having a toxic interaction with digoxin, because Lasix is very commonly used with heart failure, as is digoxin. And so that's why we check potassium in somebody who takes digoxin on a very regular basis. Dig toxicity leaves them with this yellow vision. I think we've covered that before. All right, supraventricular tachycardia above the ventricles. We know it's supraventricular because they have narrow QRS complexes. I think I count 18 QRS complexes in this 6-second strip, and the heart can't fill. And so one of the very last things that I did in an emergency room, take very good care of a very good friend of mine, right before, I think it was like my last day, they show up in the emergency room with supraventricular tachycardia. And so it was very scary. All right, so what are our choices in the supraventricular tach? Sometimes the supraventricular tach can be atrial fibrillation, and the ventricular response is so fast that we can't see that it's the atria that are causing this. So that's something to keep in mind. We can use beta blockers to slow the ventricular response down. Those are called class 2 antiarrhythmics. So class 1 sodium channel, class 2 beta blockers, class 3 mixed action like amiodarone, class 4 are the calcium channel blockers. We'll talk about all sorts of calcium channel blockers that'll be used when we have certain kind of cardiac problems. And then other calcium channel blockers will be used for high blood pressure. The calcium channel blockers that are used for high blood pressure are going to be very different than verapamil and diltiazem. They're very special. Verapamil and diltiazem have very special uses for cardiac rhythms, so I want you to think about separating them out. All right, but the drug that we will use, as long as we don't see atrial fibrillation sitting underneath, is adenosine. The same adenosine that makes ATP is the same adenosine that we will use in paroxysmal supraventricular tachycardia. Paroxysmal just means it comes out of nowhere and goes away as such until we had a better understanding of it. When we give adenosine, one of the things that's very interesting about adenosine is it'll stop the heart for 6 seconds, and it's really scary, but it always comes back. The heart rate always comes back after adenosine. So it's safe. It's considered this AV node reset. They're not sure how exactly that works, but this is commonly used in supraventricular tachycardia. And so there's going to be a test question. You give adenosine, their heart stops for 6 seconds. What do you do? Wait, because it'll wear off, and then you'll see It'll stop the ventricles for 6 seconds. You'll still see an atrial. You'll see the atrial activity while the adenosine is working. We're going to treat atrial flutter basically the same way as atrial fib. We want to make sure that there aren't blood clots up there before we try to convert that. A first-degree heart block just means the PR interval is greater than 1/5 of a second, so we measure the distance between these two. When we're in the emergency room looking up, it's hard to see. All right. But I want you to be aware of third-degree heart block, and I want you to see all those buried P waves. So you can see the atrium's making P waves. The atrium's lighting the fuse, but the fuse isn't making the firecracker go off. This person's in a full-blown atrioventricular block, third-degree heart block. And this is an emergency that people need to be able to recognize and treat. And so when we have real third-degree heart block, they're going to need some kind of external pacing. And that's something that you can learn if you're in a really good ACLS class. And again, I would urge you to take the time to learn that. However, what I wanted you to see is the 4 QRS complexes on the rhythm strip. That is bradycardia. And so we're going to talk about bradycardia in a little bit in the minutes that remain. Brady, slow cardia heart rate. So bradycardia means slow heart rate. Technically, bradycardia is less than 60. Tachycardia is higher than 100. However, there's this thing called reality, and reality means relative bradycardia. And that just means the heart is beating too slow to keep up with demand. And so I've known people who their normal heart rate is 100. That is the heartbeat that they need to perfuse themselves because they are barely getting by. And when their heart rate gets down to 80 or even worse, 70, then their heart is beating so slowly that they're not able to keep up with demand. Now, you're going to be able to identify that when you're meeting with them because they're going to be short of breath, they're going to feel winded, their heart rate's 70, and you have to get to know them that they're having relative bradycardia. So see, keep this in mind. I want you to know bradycardia is less than 60, all right? But if you meet somebody whose heart rate is 70 and they're behaving like they have bradycardia, if they're getting cardiac insufficiency, then maybe they have relative bradycardia. You're going to meet professional athletes who can run marathons in between their 100-mile runs, and their normal heart rate is less than 60 all the time. Matter of fact, maybe it gets above 60 when they're out running really hard. And so athletes can have heart rates less than 60 and not be in bradycardia. Okay, so there aren't real absolutes. But for beginners, there's your absolute right there. Heart rate of less than 60 is bradycardia. And the most important thing is, are they stable or unstable? I had, when I was a resident, we had a woman who her heart rate would just get really slow. And she felt fine. And so she would get down in the 40s, and that's very rare. Most people get down in the 40s, they don't feel good. They start behaving like they're unstable. So notice both heart rates are the same, but one person is short of breath and turning blue, and the other person's fine. And maybe they have the same bradycardia. And so that makes a difference. Do they have stable bradycardia? Yeah, they feel fine. They look fine. They're perfusing great. Like, well, our heart rate's 40. And they would wake us up over and over and over again to keep re-examining her. I'm like, well, she's stable. She's doing fine. We can wait and have the cardiologist deal with her in the morning. But if they're unstable, then we're going to have to intervene. And we can use atropine. We've talked about that before. It's an anticholinergic, antimuscarinic. And then we can use adrenaline as well, epinephrine, and then we've talked about that. And so these will be the 2 treatments in bradycardia. And so I want to go back to atropine. In the autonomic lecture, we talked about atropine in the bowels. We talked about atropine and dilating pupils. And we talked about atropine being something that military people carry around for nerve gas. And now here we are using atropine to treat emergency bradycardia. And so the whole purpose of the Section 6 lectures, or I'm sorry, the Section 2 lectures from 2.1 to 2.6 is to show you how all that stuff is connected. And even though a drug might, like atropine, you might think, oh, well, it's used for bradycardia. Well, it's used for a lot of different things as well. And so that's the perspective that we wanted to have through the Section 2 material. Well, that's certainly more than enough for one day. When we come back, we'll finish up any 2.5 stuff that I might have left out, and then we'll start covering 3.1 central nervous system pharmacology. So until then, aloha.